Thank you so much, Angie. I appreciate it. And thank you, everyone, for your attendance today. So let's begin. Today, we'll be discussing the heart of the matter, cardiometabolic testing in clinical practice. Cardiovascular disease is going to be the main topic of the day, and I'm sure you have patients that have been diagnosed with cardiovascular disease and may most likely have family members as well. So this is a consideration that touches everybody, really, especially in the United States, North America, the developing world. And it is largely a nutritional component, lifestyle disease that can be preventable. So that's really what we want to talk about today, is reducing risk and considering biomarkers that address the pathogenesis of cardiovascular disease and addressing these. So that's really, really where we want to make an effort. Cardiovascular disease is still the leading cause of death worldwide, so we want to prevent that. And over 18 million adults have cardiovascular disease. And we're seeing this not only in the United States, but we're seeing this in other countries as we export our nutrition and food system to other countries. All right. And one of the things associated with cardiovascular disease is going to be microbiome dysbiosis. This is associated with cardiovascular disease, atherosclerosis, hypertension, and heart failure. So we will not elaborate on that today, but we will consider that cardiovascular disease is associated with other systems, including the microbiome, the liver, metabolism, and things of that nature. So metabolic syndrome is what we're going to be discussing today as well, because metabolic syndrome is associated with this. It's under the same umbrella. Metabolic syndrome is estimated that up to 25% of the world's population meets the criteria for metabolic syndrome. And I do, we can consider the fact that this will actually increase as individuals as we see that post-pandemic weight gain. So with the post-pandemic weight gain, the likelihood is that individuals will not recede that weight to their baseline pre-pandemic. And so now you have a whole cohort of individuals that have a new baseline weight. And that is associated with abdominal obesity, that visceral adiposity. So that's very important when we're talking about weight management and weight distribution, because we know that visceral fat is extremely dangerous for health. Fat is not inert. It does play a physiologic function. And we'll talk about the fat-derived leptin and adiponectin later. So again, for metabolic syndrome, we're thinking about that abdominal obesity, we're thinking about dyslipidemia, we're thinking about hyperglycemia and hypertension. So with regards to dyslipidemia, we're going to look today at the lipid profile, and we're going to move beyond the standard lipid profile, because the standard lipid profile doesn't give us enough information about what is happening with the lipids. So the lipid system is a dynamic system. It is essentially constantly in motion to manage our physiology. And so we want to understand what's happening there. So we'll take a look at that. And with regards to hyperglycemia, we will take a look at the fasting glucose, and we will also take a look at insulin, and we'll take a look at the novel biomarker, Glycomark. And Glycomark really helps us to understand hyperglycemic excursions over the past 2-week period. So we're not limited to that essentially 24-hour glucose information. And of course, hypertension is also integrally related to what we'll be discussing today. So that's another consideration. All right. And then with regards to the lipid profile, instead of just evaluating cholesterol, we are going to look at we're moving beyond the LDL and the HDL. So we're going to look at the oxidized LDL, the small dense LDL, and the non-HDL cholesterol. Now, this is very important, especially today, as we see the popularity of diets such as ketogenic diet. So something that I constantly hear is that total cholesterol and LDL do not matter. And it's okay to have these elevated, generally speaking, but it's also okay to have these elevated when somebody is on the ketogenic diet. So we will see today that, yes, that is a theory, that is a thought process that does make sense, but the reason that those biomarkers are not the definitive piece of information, the reasoning is that we want to understand what's happening with the lipid metabolism and lipid balance. So we're not going to solely rely on total cholesterol and LDL. We're going to also look at HDL. We're going to look at oxidized LDL, small dense LDL. We're going to also look at apolipoprotein B, apolipoprotein A. So that information will provide us better biomarkers to understand what's happening with regards to the metabolism of these lipids. And this will also tell us about, one's considerations with regards to cardiovascular disease and metabolic syndrome, okay? And then with regards to metabolic syndrome, one point to make here is that historically, with regards to obesity, there was an ideology that the ratio of the bacterial phyla, Firmicutes to Bacteroides, would be consistent and provide us that information, and we could have some treatment strategies targeted at that. It hasn't panned out that way. So with many things in science, the more and more studies that we get, the more and more we know better. And so the Firmicutes Bacteroides ratio is not definitive for obesity. So with regards to that, we want to think of an inflammatory microbiota profile instead. So that's an inflammatory microbiome. And this all goes together because if your patient has an inflammatory dysbiotic microbiome, that actually influences hypertension, cholesterol metabolism, and then the downstream effects is that if there's inflammation systemically, that's going to predispose one to elevated LDLs, and hopefully they have appropriate HDL. But if they're not feeding their body properly, there's going to be low HDLs, and then they won't be able to compensate. So everything is really tied together. So in these individuals, diagnosed with cardiovascular disease, metabolic syndrome, we want to think about proper lipid panels. We want to think about addressing the congruent organs, including the gut microbiome and also the liver. So this is not a talk today about the liver, but I do want to mention that metabolism is highly associated with liver function. And these are all intricately connected because we're talking about metabolic dysfunction and dyslipidemia. So all of these systems do go together. Essentially, when somebody is consuming food, that goes into the microbiome. The way the microbiome is set up determines how one can handle those food items. And then depending on the substrates of that, the short chain fatty acids, et cetera, then the next step is the liver, where those are metabolized into the liver. And then those metabolites go on to signal systemic physiology. And what we are living in a time now is that historically, the most damaging insult to the liver would be from alcohol, because alcohol is essentially metabolized into sugar. And so when an individual is drinking sugar in that manner, it created a fatty liver. And now what we've learned, and I'm sure you've seen this in your patients, is that many people have fatty liver that have not consumed alcohol. So it is a metabolically induced fatty liver. And that has to do with, again, the standard American diet, the excess sugars, the sugary drinks, the sodas, the frappuccinos, the sugary coffees, all of that, okay? So just recently, I want everyone to be aware of that, is that the nomenclature has changed. So it's no longer determined non-alcoholic fatty liver disease in those individuals. It's metabolic associated steatic liver dysfunction. And this is for your patient that does not have a history of alcoholism, but they have fatty liver. And so that's a metabolically induced fatty liver condition. That does play a role with regards to cardiovascular disease, because remember, the beginning of the lipid profile is going to be diet and liver, because what happens is in a pristine environment, when we are consuming food items, our body is packaging those up into triglycerides and cholesterol, and then the lipids that we will be looking at today are mainly responsible for carrying those triglycerides and cholesterol to organs for energy. So this is an energy-rich balanced system that has actually gone haywire. So that's what we're looking at in our patients, and that's what we're addressing. So with regards to this metabolic liver dysfunction, now these are for your individuals that have an elevated ALT and they do not have a history of alcoholism, and they have no known physical stenosis of the liver. And so then they only need one of these 5 criteria to fall under this category. So again, think about metabolic syndrome, think about cardiovascular disease. They need an elevated BMI, elevated serum glucose over 100, so we'll see some of these today, or they're having an elevated HbA1c or treatment for type 2 diabetes. They need an elevated blood pressure, an elevated plasma triglycerides, or they're on a lipid-lowering treatment, and then a low plasma HDL. So of the things that we are discussing today, the glucose, the serum glucose, the plasma triglycerides, and then the low plasma HDL. So in patients with liver dysfunction, they really only need one of these to be classified in that category. So understanding this can really help our patients, because the liver is just so integral to lipid metabolism. Okay. So today we're going to be discussing moving beyond that standard lipid profile. And the standard lipid profile is also known as the coronary risk panel, the lipid profile, the fasting lipid panel, the non-fasting lipid panel, the cholesterol panel, or the lipid test. This profile generally includes 4 or 5 markers. The first marker is going to be total cholesterol, so that's measuring all of the cholesterols. The second marker is going to be triglycerides. And the third, then the next 2 markers I'll talk about together, the LDL and the HDL. So the LDL cholesterol, that's the low density lipoprotein. This is a very buoyant lipoprotein. So like the name says, it's low density, so it floats. And the HDL is the smaller, higher density. Generally speaking, people have termed the LDL the bad cholesterol. That's quite a misnomer, because essentially the LDL cholesterol isn't bad. Remember, we said a few moments ago that the job of the LDL is to take the triglycerides and the cholesterol that have been packaged in the liver, essentially, or the chylomicrons, and take it to the periphery. Generally speaking, what the LDL is doing is just basically dropping off the triglycerides or the cholesterol to be utilized for energy, or in some places to address inflammation. And so the LDL gets a bad rap, but it's not necessarily bad. It's just simply performing its function. And then the HDL, we can think of the HDL as the inverse. The HDL is the good cholesterol, but really what the HDL does is it goes to systemic circulation, and it basically is like a garbage truck, and it goes around and it picks up the excess cholesterol and triglycerides and brings it back to the liver. So it's a dynamic system. And so that's why looking at these HDL and LDL values is helpful, because it tells us, gives us an idea about how much cholesterol is taken from the liver to the periphery, and then how much is going back. And we want to have balance of that system. So that's why we're looking at the HDL to LDL ratio, okay? And then the other piece of information in the standard lipid profile is maybe the very low density lipoproteins. The very low density lipoproteins are even larger than the low density lipoproteins. They are even more buoyant, they're even lighter, and they're a step before the LDL. So that those 5 are generally, or 4 are generally in the standard lipid profile. And that's good information, but that is a good place to start. We need more information. And just a note here about the LDL value, generally the LDL, you want it to be less than 100, although I would say that value itself is not important independently. We want more information. But with patients with diabetes, the recommendation is that this should be left at less than 70 or 55, depending on the individual's cardiovascular risk. So that's just good to know, because sometimes these recommendations are not known so well in clinical practice. So just keep an eye on that. So again, with these LDLs, with these lipids, we want to understand that when we're looking at the lipid panel that we will be looking at today, this is very helpful information because it tells us a story of what's happening with the lipids. And with the lipids, structure equals function. Okay, so we talked briefly about the main lipids in the panel, in the standard panel. And so we're starting on this diagram here with the very low density lipoproteins in the top right corner. Those lipoproteins are extremely light and they're extremely large. And so those are essentially going to be traveling from the liver, dropping off cholesterol and triglycerides as needed. And then we have the intermediate density lipoprotein, and then we're going down to the LDL. So down here, we have the LDL. So this is what we're measuring generally in a lipid profile, is the LDL, the VLDLs, and then the HDLs. Now, remember, the LDLs are derived from the VLDLs, but then we have one other step. We have the small dense LDL. And these small dense LDL, these are smaller and they are denser. So therefore, structure equals function. They are more atherogenic because they can actually just get in the arteries there, and they can get a greater risk of atherosclerosis due to their size and their density, essentially. So that is what we want to think about when we're looking at our patient's panel. The next piece of information is the HDLs. And again, these are anti-atherogenic because they are the garbage trucks. They're going in and picking up the excess cholesterol and bringing it back to the liver. So the balance of these. And you can just take note here that the HDL is very tiny. I mean, it's almost 1/3 to 1/5 the size of the VLDL, and the LDLs in the middle, and the small dense LDL is even smaller and denser. The lipoprotein A, we will talk about this today. This is a genetic marker. We will look at this. Lipoprotein A is in here as well. It's a little bit different in that it really prevents the breakup of clots. So it's highly associated with clot formation because it essentially blocks breaking down clots. So we'll talk about that in a minute. But this is, so when we look at a profile, we can understand what we're looking at for patients. All right. And again, today, we're going to move beyond that basic panel. So we're going to look at information such as oxidized LDL. So this tells us how much of the LDL has been oxidized, because when the LDL is oxidized, that is the LDL that contributes to atherosclerosis. And then we're going to look at the small dense LDL. Remember, we just saw those. Those are tiny and they're heavy, so they can get stuck and create atherosclerosis, higher likelihood than the LDL itself. We're going to talk about that lipoprotein A, that small genetic lipoprotein. And then we're going to talk about apolipoprotein A1 and apolipoprotein B. So of here, apo means derived from or pertaining to. Lipo means fat, and proteins. So these are essentially proteins that are on the HDL or the LDL, and this initiates function. So the apolipoprotein A1 is on the HDL particle. So that's essentially good because it's, again, involved in that process of remediating the lipids in the periphery. And then the apolipoprotein B, that is a protein that is on the LDL, the VLDL, so all non-HDL cholesterol. And that little protein itself is associated with bringing the cholesterol particles from the periphery into plaque formation. So into the arteries. So this little protein itself is very important because what cholesterol there is needs to be brought into the arteries to create a plaque. And this protein tells us essentially the capacity for that. So this is, again, moving beyond that LDL to understand, well, what's happening with the LDL that's there. We're moving beyond just a value of LDL, and we're understanding how these lipids are functioning in physiology. Okay. And then along that nature, same consideration here, we're looking at Glycomark. This tells us about postprandial hyperglycemia over the past 2 weeks. So if your patient has gone into hyperglycemic episodes anytime within the past 2 weeks, this provides us that information. So it goes beyond the glucose, because the glucose is limited to essentially 24 hours, the fasting glucose, and this tells us about the past 2 weeks. So that's important information to have. And we will look at those adipokines, leptin and adiponectin. These are essentially derived from fat. And remember, we talked at the very beginning about metabolic syndrome and obesity and visceral adiposity. So these are derived from that. And these are very important systems that are highly implicated in eating behavior and unfortunately contribute to the pathogenesis of metabolic syndrome and obesity. Excuse me, leptin does, adiponectin is protective. And then we're going to look at the markers of inflammation. We're going to look at plaque. So plaque is an enzyme that is associated with the formation of atherosclerotic plaques. When we have that oxidized LDL and it is taken into the artery with that apolipoprotein B as the carrier, then the next step is that it will form a plaque. And the plaque marker is an enzymatic marker of that function, essentially. And so it gives us an idea about that pathophysiology. And the next marker of inflammation we will look at is homocysteine. We know that homocysteine is a biomarker associated with cardiovascular disease and coronary events. So we definitely want to have that information as well. And with regards to the inflammatory markers, we're going to look at CRP, hsCRP, because this marker is so important to understand an individual's baseline inflammation. Because again, all of these processes go together, because if somebody has a value of LDL or cholesterol, it really does depend how much of that is associated with the end product of inflammation. So all of these markers go together, and it does tell us about our patient's risk. So we can't just look at LDL and total cholesterol. We want to understand all of this information to really assess our patient and help them with regards to their own physiology. All right. So we're going to start looking at the real LDL culprits, not just LDL. We know that LDL provides us a piece of information about value, but we want to understand what is happening with the LDL. The first piece of information we have is the oxidized LDL. Now, the oxidized LDL, this is a risk factor for cardiovascular disease, and this is independent of LDL. Oxidized LDL, that is that portion of the LDL that has been oxidized. So you want to think about their lifestyle, whether they're smoking. We know smoking is an independent risk factor. Toxins, oxidative stress, things of that nature. Because that oxidized portion of the LDL is that which will be brought in to create the atherosclerotic plaques themselves. So this is the initiation and the progression of atherogenesis. Another marker is that small dense LDL, so we're going to look at that. And then lipoprotein A, which you may or may not be familiar with, that is a genetic marker, but is still important information to have. Okay. The next piece of information we have is that small dense LDL. Like I said, this is very small. We could see based on particle size that it is extremely atherogenic. It is, again, an independent risk factor. It readily penetrates the endothelium and carries less glutathione tocopherols. So this is readily oxidized and taken up by the macrophages. Again, this is associated with an elevated triglyceride and a low HDL. So elevated triglycerides, we'll take a look at that, largely tell us about the fed state. So those are the triglycerides that's coming from diets. And then when somebody has a lower HDL or an apolipoprotein A1, they're not bringing the cholesterol back. And so they have elevated small dense LDL, and that's going to go to atherosclerosis. Really important here, again, the intervention is going to be the lifestyle modification, the dietary modifications, to cease smoking, consider exercise, losing weight. Niacin is an important one here. EPA and DHA is important. And then you can always consider fibrates and statins. Okay. And then statins may increase the small dense LDL with the normal triglycerides level. So maybe dietary intervention is going to be the best. We're going to take a look at lipoprotein A. Lipoprotein A is the genetic marker. So really it's important to get this information for your patient at least once per their lifetime. This is an independent risk factor for premature heart disease, thrombosis, and stroke. And then the thing with lipoprotein A is it stimulates the secretion of tissue plasminogen activator inhibitor 1. So essentially when the body has a process that clots are going to form and it is going to degrade them. But if you have lipoprotein A, those clots will not degrade themselves, and therefore the increased risk of clots really goes up for these individuals, and this is genetic largely. So essentially there's potentially no good interventions. You can decrease this slightly by decreasing the total value of lipoproteins, and then that would be via diet, exercise, and there is some evidence for niacin, and you could consider the pharmaceutical niacin. That's an option there. All right. And so the lipoproteins, apolipoprotein A1 and B are very important. Apolipoprotein A1, like we said, is essentially a lipoprotein that is on the HDL cholesterol, so it is cardioprotective, versus the apolipoprotein B that is on the non-HDL cholesterol, so that's LDL, VLDL, and it is taking the cholesterol into the arteries. There are some people that believe we should actually just look at apolipoprotein B as a biomarker because it's that important. I'm not going to advocate for that, but that theory is out there. All right. So like we said, apolipoprotein is on all of those. Okay. And on lipoprotein A. And then with regards to the markers of inflammation, we are going to talk about plaque, like I said, homocysteine, and CRP. So we're going to look at these all together. This tells us about the progression of cardiovascular, coronary artery disease, instability, and the risk of cardiovascular events. And then it's important because if your patient has LDL and oxidized LDL, you want to see about these markers to understand how much endothelial inflammation is there, because these all go together. Again, inflammatory markers, this is something that we do know. There's a large body of evidence with regards to this. Lifestyle, diet, exercise. With regarding inflammation, you can think about that EPA, and the DHA, CoQ10, things like that. And then the last puzzle piece here is going to be hyperglycemia. So we want to move beyond that fasting glucose, insulin, and hemoglobin A1C. We're going to look at that serum glycomark, and that tells us what occurred over the past 1 to 2 weeks. So it's very important to know this information. And then the glycomark itself is actually correlated with cardiovascular disease and diabetes. So glycomark is an independent factor. And then also glycomark, interestingly enough, glycomark was very important in predicting mortality in hospitalized COVID-19 patients with and without diabetes. So there's a role for glycosylation in that manner as well. And here we'll take a look at the cardiovascular profile, the metabolic risk profile. Here you'll see the traditional markers at the top. So that's how the profile is organized. And then we'll look at the specific markers that we talked about. Non-HDL, this is everything besides LDL. So this is a very important value here. We'll look at that oxidized LDL, the small dense, that lipoprotein A, and then we're going to look at the ratios. So how much of the total cholesterol is HDL? We're looking at that LDL to HDL ratio. We're looking at how much of the total cholesterol is oxidized, how much of that total cholesterol is small dense, so we know that. And then we're looking at that apolipoprotein B to apolipoprotein A1 marker. That is a very important marker because remember, apolipoprotein B is telling us how much of that cholesterol is being brought into the arteries. So we want to understand that process, how much is being brought into the arteries and how much is going along on the HDL dump trucks back to the liver. So it's a very dynamic system. Of course, we want to look at those inflammatory markers and the absolute values of those apolipoproteins. And then we have a metabolic section of the report here. We have insulin, glucose, and then we're looking at glycomark. Then we're looking at that leptin and adiponectin together, those visceral derived, adipocyte derived. And then we're looking at the ratio of leptin to adiponectin. We'll see a case with that. And then we're looking at markers of kidney conditions. So cystatin C and creatinine. Cystatin C is a very sensitive marker. All right, so let's get into our cases here. Our first case is a 58-year-old female who is on the ketogenic diet. This individual consumes eggs, lamb burgers, and cream regularly. The weight is 142 and 5'4", BMI 24.37. We know BMI is not the best marker, but that is some information that we have. So let's take a look at the lipids. Okay, so for this patient, we can see that the patient's been on the ketogenic diet, and I'm sure you have patients on the ketogenic diet. So the first piece of information we have is total cholesterol. So total cholesterol is 338, so that is elevated. Triglycerides are healthy within range, so that's really good. I mean, I think that makes sense. If you're not on a standard American diet, your triglycerides are going to be healthy. Their HDL is very good at 88, so that's awesome. And then their LDL is too high. So their cholesterol and LDL are too high, but their VLDL is good within range. So what's happening here is that the diet looks good, the VLDL looks good, but then the LDL is too high, making the total cholesterol too high. So so this patient, if they had just run that panel, they might have said, okay, that's fine. I know my total cholesterol and LDL is going to elevate because I'm on the ketogenic diet. So I'm okay with it. My HDL is 88, so that's okay. Not quite. That's why it's very important to move beyond the LDL marker and understand the oxidized LDL and the small dense LDL, because remember, the oxidized LDL and the small dense, those are extremely atherogenic, and it gives us a better piece of the puzzle, better piece of information than just LDL or total cholesterol. So for this patient, we can see that the non-HDL cholesterol is very high. So everything aside from the HDL is too high, but then more importantly, their oxidized LDL is very high. So we know that they have oxidized LDL, and I'm just going to jump down here to the apolipoprotein B. Apolipoprotein B is too high, and then plaque is too high. So we know that their oxidized LDL is being taken up by the apolipoprotein B, entering the arteries and contributing to plaque formation. So we have a good piece of the story here. And again, if you had just ran the standard lipid profile, you would miss that information, okay? So the oxidized LDL is too high and the small dense LDL is too high. Remember, these are independent risk factors. So this is very important information. Lipoprotein A looks good. This is a genetic marker. And then we're talking about the ratios. So the ratio of HDL to total cholesterol makes sense. It's within range because they have a lot of HDL. Their HDL is good at 88. But then their LDL to HDL is not too healthy because their LDL is too high and their HDL is proportionately too low. Even though that HDL is high, it's about the ratios, right? So the ratios are very important because depending on what's happening at the beginning of the report with their cholesterol, there's many different factors. Sometimes cholesterol will be within range, but you want to look at the ratios to understand what's happening with the lipids that are there. Okay, so in this example, HDL is very healthy, but that ratio is still outside the reference interval. So even though they have a lot of HDL, they have too much, they don't have enough in proportion to their LDL, okay? So that's important information. And then the oxidized LDL to LDL-C is technically within range because they have a lot of LDL, and of what the LDL that they have, the proportion of oxidized LDL is appropriate, but we know it's just great. It's just too much to begin with. So we're starting with too much, but the ratios are within range, but there's just too much. Okay. So again, the ratios are important, and as are the values. So the rest of these are pretty good, but then again, we see the inflammatory marker, that plaque is that enzyme is there, letting us know that the oxidized LDLs have been brought into the arteries. CRP is a little bit too high, so you can address it that way as well. And then we talked about the Apolipoprotein B being too high. Their insulin is lower. Their insulin is 1.5. That's fine. We'll talk about the ketogenic diet ketones may decrease insulin, and then the insulin value, we can talk about that in a little bit. Their leptin is too low. They may be genetically low leptin. So for this patient, we have cholesterol is elevated. More importantly, the non-HDL, like we said, the oxidized, the small dense LDL, and the plaque are all elevated. So the non-HDL is highly suggestive of chylomicron remnants. They're very atherogenic. And then they have the high plaque with the elevated CRP. So this is a significant risk profile. The oxidized LDL, the small dense LDL, and the very high apolipoprotein B, like we just discussed, very significant red flags. Other markers, the creatinine may be due to poor muscle mass. The low insulin can be lower in the presence of ketones. So you will see this on your patients that are on the ketogenic diets. The other thing I would say is there's different ideas about what the insulin value should be. Some people are saying less than 10. Some people are saying less than 6. Some people are saying less than 2. The value was, I believe, 1.5 or 1.8. So that's not going to be the emphasis of the treatment at this point, okay? So this patient needs to think about reducing abdominal visceral adiposity. There could be a cortisol, adrenal, thyroid consideration here. Leptin may genetically be low, so you need to address and retest in 6 months. So this is an example of why it's very important in especially ketogenic patients to do the profiles. This patient would benefit from the intake of low carbohydrate, vitamin C containing foods, right? Because they have that oxidized LDL, so they need to get these back in. You also additionally need to consider supplementation of NAC, sulforaphane, curcumin, and CoQ10, those antioxidants. And then, of course, the fats, right? Because someone can be on a ketogenic diet and they can be consuming soybeans and canola oil, fats all day long. So we need to decrease the intake of the polyunsaturated and prioritize those monounsaturated fats, those avocado oils, peanut oils, olive oil, those oxidation resistant fats, because the patient has high oxidized LDL, okay? Our second case is a 51-year-old male on the standard American diet. So this patient consumes fast food regularly, and this patient also is drinking green tea instead of water for health benefits. And this patient's on Lipitor, no time for exercise. So you have this patient in your practice, I'm sure. So let's take a look at their information here. Cholesterol actually looks very good. Triglycerides look very good. So that makes sense because the patient's on the medication, so that's working. HDL is too low though at 38, so we definitely want to increase that HDL. You could consider niacin, some lipid, the fats, EPA, DHA, things like that. So this looks reasonable. The oxidized LDL is a little bit higher, so we could talk about decreasing oxidation, antioxidants. And then the CRP though is very high at 4.3, and the homocysteine is way too high at 12.3. So there's a case here where, yeah, the lipid profile looks healthy and that medication is fine, but we do want to address the other considerations here, the homocysteine, the CRP, even the plaque is heading up there. So this is a case where you want to consider the diet in addition to, right? And then further down, I will mention this, that leptin is very high and adiponectin is very low. So this patient is what we are calling leptin resistant. So what happens is when we're in a fed state, that will signal the leptin that's housed in the adipocytes, so in the fat, to signal satiety in the brain. And what happens is, after individuals have been in fed states for an extended period of time and they have excess abdominal visceral excess abdominal fat, excuse me, what happens is the signal, that negative feedback will stop. So people will not feel full after they're eating. The more visceral fat you have, the less likely you are to feel full after eating. So it's a vicious cycle. So my heart really goes out to these patients, and we need to treat them with compassion because this signal pathway is off. And the way you can tell that is by the values of leptin and adiponectin. So they do not feel full after they are done eating. So reduce that visceral adiposity, and then you can hopefully regain homeostasis for this mechanism. Our third case is a 66-year-old female. She has had 2 strokes within the past 2 years. They have seemed to be under control with a blood thinner prescription. This patient is not obese, but the consideration here is there any more information from a lipid profile in terms of why this individual is having strokes? Let's take a look. Cholesterol looks very healthy. Triglycerides look healthy. Look at this HDL 78. That's awesome. That's very good. Very, very good. Okay. So we can see right off the bat, things are really within range. But then when we look at this LP little a is genetic. It is very elevated for this patient. So even though the lipid profile is healthy within range, that genetic piece is there. So probably a SNP or something of that nature for this patient, genetic inheritability, that the LP little a is too high. Remember, what does LP little a do? LP little a basically prevents the body from breaking up clots. So exactly, in this patient, when clots are formed, they're not being broken up, and the patient ended up with, unfortunately, 2 strokes within the past 2 years. So with regards to reducing LP little a, potentially there's not much that can be done because it is genetic. And you can't really go and decrease this cholesterol any further to decrease the LPA. So in this case, it's going to be exactly what they're doing, keeping them on the blood thinner and things of that nature and monitoring them. Of note, the insulin is at 1.8, but again, that might be within range. Not too concerning there. Leptin is at 5.2. This patient is lower, they're thin, so that they don't have a lot of body fat. The opposite of the patient we just saw, that makes sense. And then our last case here is a 64-year-old male. He eats healthy and he has a history of hypercholesterolemia. What is healthy? We'll see. So the first report is going to be in May of 2023. And this patient shows that their total cholesterol is too high. We're at 242. Triglycerides are too high. Their HDL is too low. Their LDL is too high. So right off the bat, we can see their cholesterol is too high. Triglycerides, they're eating not healthy. Their HDL is way too low to their LDL, and their VLDL is moderate. Non-HDL is too high, so that's everything besides the HDL. And then the LDL they have there is oxidized. That oxidized LDL is elevated. They have the small dense LDL. Their LP little a is okay, so we're not thinking about a genetic consideration, but we're not surprised. These ratios are off. Total cholesterol to HDL is too high. Cholesterol to HDL, there's that LDL to HDL marker is off. And then the of importance here, the apolipoprotein B to apolipoprotein A1 is off. Apolipoprotein A1 is too low because HDL is too low, and apolipoprotein B is too high because we have too high LDL, small dense LDL, VLDL, etc. So this patient is running the risk of having those lipids brought into the arteries via this apolipoprotein B. And the plaque looks okay at this point, so that's healthy. So let's take a look 6 months later, see what the patient did. Okay, so this is September 2023. The patient moved away from their diet to a more cardiac healthy diet. I believe it was a Mediterranean-like diet. So look at this. Total cholesterol looks very good, okay? Serum triglycerides are elevated, but let's take a look deeper. HDL is still too low at 35, but LDL is a lot better at 93. Okay, VLDL is 56, so that's still too high. So VLDL and triglycerides being high in this profile, it makes me think about diet. Did the patient have a fatty meal recently? We can see triglycerides increase just a few hours after a fatty meal, shortly after, and it takes many hours to go down. So because total cholesterol is lower, but VLDL is higher and triglycerides are higher, so it's making me think about recent dietary intake. But let's get more information. The non-HDL is still a little bit higher. The oxidized LDL, though, is a lot lower. Small dense LDL is still a little bit higher, but when we look down here, let's go past the ratios all the way to the bottom, their apolipoprotein B is a lot lower. So that tells me that within the non-HDL cholesterol, that value is a lot lower. And so there's a lot less capacity to bring those cholesterols into the artery. So this is actually a promising profile. So that I would test this again in maybe 3 months just to see, because the cholesterol and the very low density lipoprotein maybe reflect recent dietary intake. The total cholesterol and the LDL are decreasing. The oxidized LDL decreased, and the apolipoprotein has decreased. So oxidized LDL, apolipoprotein decreasing, the patient's heading in the right direction. So much improved. There are still some efforts to be made, but this is actually a really good moving in the right direction. Okay, so we talked about the comprehensive cardiometabolic profile. I would just think about the fact that this system is intricately connected to various other systems, including the microbiome. So we're going to consider testing that with the GI 360. The other consideration is going to be, we didn't talk about metal exposure, but there is some considerations there with metal retention and atherosclerosis. There's a hormone consideration, absolutely, including also thyroid hormone. Vitamin D is also associated here. And then, of course, methylation, especially in those individuals with the elevated homocysteine. All right, so thank you so much for your attendance today. Are there any questions that I could answer at this point?